Today, we're excited to continue our monthly series focused on clinical trials in glomerular disease. As we've outlined previously, this series was developed as a collaborative effort between Nephrology Kidney International, IgA Foundation, the Gateway Initiative, and Clinical Trial Collaborative, as well as Additional Support Kidney Health Initiative and American Society of Nephrology. We've had 2 excellent sessions to date, and we anticipate continued interest and excitement today. Our disease of the month is FSGS. For practicing nephrologists, seeing FSGS come back on a biopsy report can be very disheartening. While we know that there are those that are steroid responsive, we brace ourselves for helping our patients cope with the massively disrupting side effects they will likely experience as they remain on high doses of steroids for months. Even more disheartening as we know that for many, despite bearing that burden for many months, their condition will be no better. And then when they look in the mirror, it's a constant reminder of how disease has changed their life, and that treatment can oftentimes feel worse than the disease itself, especially when the treatment fails. The nephrology community clamors for better options. We hope to introduce some of those potential future game-changing interventions through these sessions. As before, we are fortunate to have 4 individuals who have dedicated much of their lives to understanding the disease and forging better paths for patients with FSGS. To start, we'll have Dr. Debbie Gibson, Professor of Pediatrics from the University of Michigan. Dr. Gibson will walk us through the current state of FSGS, including epidemiology, current treatment options, and where the gaps exist. Next, we have Dr. Martin Pollack, Professor of Medicine from the Harvard Medical School and Beth Israel Deaconess Medical Center. Dr. Pollack will explore an updated understanding of the molecular pathways of disease development in FSGS and potential novel targets of therapy. Following that contextual presentation, we have more in-depth discussion of 2 active clinical trials and their corresponding agents. First, we'll have Dr. Howard Trackman, Professor of Pediatrics from the NYU School of Medicine, who will outline the details of the Duplex trial, a phase 3 randomized controlled trial of sparsentan, a combination angiotensin II and endothelin A antagonist for treatment of FSGS. And lastly, we have Dr. Demian Model, Associate Professor of Medicine from University of North Carolina, who will outline the details of the Poteau trial, a phase 2 open label study of PF 067305112, an antagonist to SLT2 in the treatment of primary FSGS. Our moderators today include a representative of the patient voice, once again, Kelly Helm, the manager of patient engagement at NephCure, as well as a parent of a patient with FSGS, And as before, we have Dr. Kurt Campbell, Associate Professor of Medicine from the Icahn School of Medicine at Mount Sinai, Dr. Ali Poyan-Mir from the Permanente Medical Group in San Francisco, myself from the Chicagoland area, and Lauren Lee, the Chief Research Officer of NephCure Kidney International. So thank you all for joining us today, and thank you again for our speakers, and we look forward to an exciting session.
Thanks so much, Sunil. Lauren, did you want to make a mention of the Gateway briefly?
Yes. Hi, everybody. This is Lauren Lee. We're just going to show you a couple of slides quickly to introduce a website and a platform, not only physician-focused, but primarily in its current form, patient-focused. This can be reached at www.kidneyhealthgateway.com. And this is really NephCure's answer to helping make clinical trial opportunities more accessible to the patient community, and soon to be rolled out into a version that will be more physician-friendly. And this is just a brief couple visuals to show you. This is the landing page, which walks patients through a process to share basic health information. And this really, there's a back-end algorithm that matches them based on their responses to clinical trials in their zip codes that are right for them. And then thirdly, really ask the patient to to indicate their interest, and that connects them directly to a trial site. So as you are hearing about both the Duplex study as well as the Poteau trial, we hope that you will keep this in mind, not only just as a resource potentially for yourself as a physician in a busy practice, but also to share with patients. Thank you.
Thanks so much, Lauren. So with that, we'll begin with our presentations. Our first speaker is Dr. Debbie Gibson, and she's a professor of pediatrics in the Division of Nephrology at the University of Michigan. And Dr. Gibson is really one of the most prominent clinical trialists in the FSGS space. She's led a number of multi-center studies and has a special interest in patient-reported outcomes and pediatric clinical trials. She will speak today on the FSGS epidemiology, therapy, and the unmet need. So Dr. Gibson, welcome.
Thank you so much. I appreciate the invitation, and good morning, everyone. My task today is to talk briefly about the epidemiology of FSGS, its therapy, and to highlight a bit about the unmet need that tees up what comes forward. And I don't think I have control of the slides, so I'll just say, please forward. These are my disclosures, and please proceed. When we think about the incidence of FSGS, there have been a couple of publications recently that have been really quite nice. One coming from Kaiser Permanente that evaluated age and sex-adjusted rate of FSGS per 100,000 person years. And when we look at this across time, we see the typical estimates between 2 and 3 per 100,000 patients up until 2010, and then this particular plot shows an uptick after the 2011 time period. When you look on the right-hand panel, Olmsted County now has a very narrow sort of view of prevalence, but a nice population-based study, again, that looked at FSGS per 100,000 person years. And again, between 1994 and 2003, from an incidence perspective, we moved from approximately 1.5 per 100,000. And then moving into the next 5-year period, we moved up to, again, about per 100,000 population. When we think then from incidence, new patients, to prevalence of FSGS, this is a question that comes to us all the time. How many patients have focal segmental glomerulosclerosis? We used a few ways to try to estimate prevalence. One looks at essentially prevalence, looking at from the prior publications to times the estimated duration of disease from published data. The second is to use end-stage kidney disease population and back calculate from the US RDS data. And the third is to look at CKD prevalence and calculate that forward based on the proportion of CKD that is attributable to FSGS. When looking at these in 3 different ways, essentially we come to an average prevalence population in the US of approximately 154,000 patients with a combination of primary or secondary FSGS, or 47 per 100,000 patients. And then when we think about primary FSGS, about 40,000 patients with primary FSGS in the US as a point prevalence, with an estimated prevalence of 12 per 100,000 population. Go ahead and move forward. When we think about this differently, right, most of our publications that are out and about in the field look at the proportion of kidney biopsies that have been conducted that are attributable to FSGS. And this publication comes from Southeast, essentially the Glomerular Disease Collaborative Network by Michelle O'Shaughnessy, and it shows that across the age span, left-hand panel, approximately 20 to 30% of patients with a glomerular disease biopsy, right, have been attributed to FSGS in this particular cohort. And you see the differences in percentages by age, starting from 0 to 9, going up and peaking at around the 30 to 39 year age group, and then coming down again in our individuals who are 60 and above. We also, in this particular study, see the same trend. We recognize this history of expecting sort of more FSGS over a period of time. This was well reported in the literature between 1985 and 2000, with a plateau between 2000 and 2005, and then a slight decline in essentially the proportion of biopsies attributed to FSGS in that subsequent years. Important to note in this particular group is that 45% of the individuals who were biopsied in this group were of African descent, and so that is just something you need to put in your thoughts as you're considering what proportion of your own personal biopsies of patients with glomerular disease are attributed to FSGS. Go ahead and move forward. Historically, we've thought about FSGS therapy, and we're going to recognize these buckets, right? This is a publication from 2011, and quite frankly, oftentimes today, we're still thinking in these terms, right? Is the FSGS that's before us a patient that has immunologic disease? Is it a person who has genetic disease? Or is this a secondary or hyperfiltering disease? And to a degree, this can be helpful, but also challenging because there are some common pathways and mechanisms that we'll talk about later today and in future that really cross the lines across these sort of three traditional buckets. But then again, as we then pick up therapies, go on to the next slide, our therapies tend to follow that very traditional view, right? In 2019, FSGS therapy begins with renin-angiotensin blockade, which may reduce your proteinuria by about 30%. Sorry, we've lost our formatting as the slides move from place to place. I beg your pardon. Prednisone, or corticosteroids, that again capture some control of proteinuria in 30 to 50% of the patients, depending upon your patient base. Calcineurin inhibitors may be essentially your codominant therapy with RAS blockade, or may follow prednisone. And then once we get past calcineurin inhibitors, we begin to look at other agents. And we're feeling a little bit what I would consider to be sort of desperate by this point, where folks are picking rituximab, mycophenolate, some other therapy, because we're finding ourselves having difficulties finding a therapy that's both acceptable to the patient and having some disease control. And go ahead and advance. The challenge that we know in 2019, how we're picking these very traditional therapies off the shelf, is that there are no guidelines essentially to help us to match the right therapy with the right patient at the right time. So the biomarkers don't help us, the diagnosis, the demographics, so we struggle with those things in the usual clinical practice. The side effects are oftentimes from our patients reported back to be really unacceptable and having an influence on essentially patients who are coming to say, I have to stop that medication, I can't take it anymore, or they have stopped the medication and haven't yet told you that because they love their providers and have a good relationship and have a difficult time expressing the fact that staying on those medications can be quite difficult. And then, of course, we understand the problem with treatment resistance. Next slide, please. And so what happens, right, when our therapies are not working? Our challenge is the disease is still progressing. So patients who have treatment resistance have progressive loss of kidney function and really an accelerated decline or step towards kidney failure in those individuals who can't achieve at least a partial remission of proteinuria. And of course, we all recognize the risk of essentially post-transplant recurrence of FSGS. And this becomes a problem for us because, of course, we have a loss of allograft survival in that patient population with a median time of graft survival of 5 years for individuals who have recurrence of disease. So you lose a good 5+ years of allograft survival. This is important, right? Recurrence of disease may bring the symptoms of the disease that were really the problem that you started with, and so that's quite difficult. It foreshortens the transplantation time, and so all the good parts of transplant. But the other component to remember is still transplantation can be, and recurrence can still be managed, and so it doesn't mean that you lose the transplant immediately. Those transplants can actually help an individual still have improved quality of life even when the disease recurs. And so we still consider to be transplantation a quite viable renal replacement therapy option. It's not our preferred, because our preferred is actually to control the disease is when the native kidneys are still functioning. And that's my last slide, so I get to pass on to the next person.
Thanks so much, Dr. Gibson. So our next speaker is Dr. Martin Pollack. He's a professor of medicine at Harvard Medical School and chief of nephrology at Beth Israel Deaconess. Dr. Pollack, of course, is well known for seminal discoveries on the genetic basis of kidney disease and nephrotic syndrome, FSGS in particular. He studies the biological mechanisms of APOL1, alpha-actinin 4, inverted formin, and numerous other genes. And Dr. Pollack today will be speaking on targets and pathways for new drug development in FSGS. So welcome, Dr. Pollack.
Thank you. Can you hear me?
Yes.
Am I on? Okay, great. And then I guess I don't control the slides here, correct? Right. So yeah, I was asked to show no more than 8 slides about the topic of of understanding targets and pathways for new drugs and drug development. This will be just a very kind of brief and general overview. So, you know, when we talk about targeting FSGS and how to treat FSGS, you know, I mean, the question itself is already problematic. You know, when someone asks me, you know, how do you treat FSGS? I feel like it's almost a trick question. It's like, how do you treat shortness of breath? Do you treat it with a diuretic or with an antibiotic or with a beta agonist? I mean, it's not quite that. It's not a perfect analogy, but you know, it makes the point that, you know, FSGS isn't really a disease, and we, you know, because we're in the habit of talking about it as if it were a disease, but it's, you know, it's really not. You know, FSGS, there are over 50 rare single gene forms of FSGS or relatives of FSGS, steroid-resistant nephrotic syndrome. FSGS is now, it's clear that it's phenocopied by mutations in several non-podocyte genes. In other words, people who are given a diagnosis of FSGS histologically are enriched for mutations and things that we don't typically think of as podocyte-driven gene defects. You know, if you look at various genetic studies, it's probably 75%, 80%, maybe more, is not caused by a highly penetrant single gene defect. It's likely immune system or inflammatory mediated. And you know, so we have this problem that a lot of the biggest advances in understanding FSGS and podocyte disorders have come from genetics, but still the vast majority of what we call FSGS is not explained by single highly penetrant genetic effects. Then there's this whole issue of secondary versus primary. But the bottom line is treatment, you know, I think most people would agree, is going to need to be individualized based on more precise phenotyping. And that phenotyping might include genetic testing, genotyping. So what makes a good target? Well, for developing a drug, you want something that shows clear evidence of having a role in the disease process, in this case, FSGS and nephrotic syndrome. Ideally, you would like evidence that targeting that pathway or protein will not have serious adverse effects. And you know, that really varies from target to target. I mean, there are several of the slit diaphragm proteins that we would like to be able to, say, repair or make work better are really podocyte specific. So one wouldn't expect to see large toxic effects of a therapy targeting many slit diaphragm proteins. On the other hand, there are pathways that are, you know, universal to all cell types. And so taking a long-term therapy that does things like affects, you know, cell division, the actin cytoskeleton, things like that, are going to be trickier. Ideally, one would be able to assess the targeting the particular pathway or target in some kind of preclinical model, a cell model, an animal model, or increasingly things like organoids or glomerulus on a chip models. And also, you want to be able to identify the patients that are going to respond to that particular targeted therapy, unless you know, the idea is that all FSGS will respond to particular therapy, which is probably not going to be the case for most therapies which will be effective, given the very non-specific nature of the term FSGS. Continuing. So there's a lot of excitement about the notion of genetics as a source of potential targets that drug companies talk about, genetically validated targets. So just to give a few examples, one example would be this TRPC6, this channel which, when mutated, has been shown to cause highly penetrant forms of steroid resistant to FSGS. Multiple different mutations in TRPC6 have been identified. It's inherited as a dominant trait. TRPC6 is a non-selective cation channel. It localizes to the podocyte and specifically to the slit diaphragm. Most mutations seem to be gain of function. Mutations in TRPC6 make the TRPC6 channel hyperactive, and there have been various reports identifying increased expression of TRPC6 in some glomerular diseases. So the notion here would be that inhibiting TRPC6 would be a potential therapeutic strategy. And this is, I believe, being pursued by various individuals and companies, but this is the basic idea that TRPC6 is a rare, mutations cause a rare form of glomerular disease, but it probably is pointing us to a pathway that might be relevant to not just people with these mutations, but more generally inhibiting this might inhibit a pathway that's hyperactive in FSGS. Alternatively, another family member, TRPC5, has been reported to be a mediator of FSGS via activation of the RAC pathway, and in some animal models, inhibition of TRPC5 has been reported to be effective. And so, we'll be eager to see if this translates into effective human therapies. The actin cytoskeleton has a prominent role in the genetics of FSGS. Multiple components of the actin cytoskeleton have been implicated in monogenic forms of FSGS and nephrotic syndrome, including actinin-4, INF2, and others. But it's, how do you target the cytoskeleton? One might do it through upstream signals, for example, through TRPC5 or TRPC6, through small molecules that alter cytoskeletal function. But again, this is tricky. The question has to be, when you say target the cytoskeleton, what are you trying to do to the cytoskeleton? Are you trying to increase cytoskeletal rigidity, actin turnover? Do you want to make the cytoskeleton more flexible, less flexible? So, again, genetics has pointed us to a particular biological pathway, and figuring out how to target is of course, not trivial. Next, so slit diaphragm, of course, is worth pointing out. Mutations in Poteau, the Poteau gene NPHS2 are a very common, are among the more common forms of a rare disease of autosomal recessive FSGS. And as people know, Poteau is a cell surface slit diaphragm protein, associates with nephrin. And some mutations in Poteau are clear loss of function mutations. In other words, they create an absent or truncated proteins. But other point mutations may affect the function or trafficking of Poteau into the cell membrane. So for a lot of cell surface proteins, like Poteau, people are interested in the idea that you might be able to use chaperones to coax proteins to behave more normally. Maybe if a mutant form of Poteau isn't getting to the slit diaphragm normally, you can coax it to get there, and then it will behave better, despite having a mutation. This is not applicable. This would be a super specialized or super personalized form of therapy, because it would be relevant. Not you'd have to divide people not just into the people with Poteau mutations, but the subset with particular Poteau mutations that cause particular defects in trafficking. So personalized medicine, although it's a noble goal, it will be challenging. Continuing, of course, it's also important to point out that FSGS is not always a primary podocytopathy. I mean, you could argue whether or not this is due to sort of errors or sloppiness in initial diagnosis, but the fact of the matter is that in a lot of studies, a lot of people identified as having FSGS are found to have mutations in UMOD or in type 4 collagens, for example, which we don't think of as really podocyte-based forms of glomerular disease. So whether or not you want to call people with these mutations as having FSGS or not, presumably you would treat someone with a UMOD mutation as a form of UMOD-associated kidney disease, and someone with, COL4A4 mutations as like you should treat someone with Alport syndrome rather as a typical FSGS patient. So again, this is why, genetic diagnosis, I think, is going to be increasingly important when as we try to personalize therapies for this broad category of people with FSGS. And then this is just a slide I took from a recent review from Alessia Fornodi and Nick Pullen, just talking about the various potential targets for treating FSGS. And these include, trying to target circulating factors, remove such factors from the circulation, cell signaling molecules that seem to modify podocyte behavior, metabolic factors, SGLT2 inhibitors seem to be quite effective in diabetic nephropathy by mechanisms that are not fully understood, and people have raised the question that maybe these will be effective in other forms of podocyte diseases that are not associated with hyperglycemia. Of course, one can consider targeting the repair fibrosis process, which is the sort of the detrimental response and how the glomerulus often responds to a primary podocyte injury. I mentioned the cytoskeleton. ApoL1 seems to be a strong risk factor for kidney disease and FSGS in people of recent African ancestry. There are inflammatory pathways that people have thought about targeting. I think this is certainly an interesting time. A lot of people, laboratories, companies are exploring a lot of therapeutic targets, and hopefully we will efficiently be able to examine these therapies in the appropriate patient populations and make progress with therapy development. I'll stop there.
Perfect. Thank you, Dr. Pollack. That sounds like a perfect transition for us to explore some of these specific trials. So as we said, the next two discussions will be on two specific studies. First, we have Dr. Howard Trackman, Professor of Pediatrics at NYU School of Medicine, who will be discussing the Duplex trial. He's been a PI for many NIH and industry-sponsored clinical trials, as well as observational cohort studies of children and adults with glomerular disease. He's been a long-term collaborator and valuable partner with NephCure Kidney International. So thank you, Dr. Trackman, for sharing your time with us.
Sure. I hope you can hear me.
Yeah, you're good.
I know you can't see me, but I'm nothing to look at. So this is my charge. My charge is to review the Duplex trial, the brief overview of the rationale, the patients that would be eligible, the outcomes, and then hopefully charge to continue. First slide. This is just a brief sort of targeted summary of material that Deb had gone over. This is to highlight that proteinuria is a hallmark of FSGS, and we as clinicians rely upon the reduction in proteinuria as a measure of efficacy of treatment and hopefully modification in long-term prognosis. There are lots of different ways that people have looked at proteinuria. Achieving a complete remission is obviously a favorable sign, and that's been proven in other diseases like membranous and similarly in FSGS. The question of a partial remission is something that's been kind of re-examined. The classic definition is a reduction in proteinuria by 50% to a value less than 3.5 grams per day. Recently, in conjunction with the people at Neptune and reviewing the FSGS clinical trial, there has been this new modified FSGS partial remission endpoint, which you'll see plays a role in the endpoint analysis of the Duplex trial. Debbie has gone over this notion of primary and idiopathic versus genetic forms of FSGS. We think that your genetic forms generally are steroid resistant, but presumably less likely to recur post-transplant, whereas the other forms of FSGS may reflect some primary disturbance in the immune system leading to the elaboration of a molecule that increases glomerular permeability and provides the rationale for much of the agents that we use. Next slide. The sparsentan trial, the Duplex trial is testing sparsentan, which is not a targeted therapy. It's a drug that builds on what we know about the pathophysiology of really the progression of renal disease, glomerular disease in particular, characterized by proteinuria. We know that both the endothelin via activation of the type A receptor and angiotensin 2 by activation of the AT1 receptor can mediate fibrosis and alterations in glomerular function, mesangial proliferation, deposition of matrix. And the innovation of sparsentan is that it was some clever guy who thought, or woman who thought, to combine a molecule that has molecular features that inhibit the ETA receptor and the angiotensin type 1 receptor into a single molecule, and ostensibly simultaneously block these two pathways that are implicated in proteinuria, glomerular barrier dysfunction, and the progression of renal disease. This drug was originally developed for the treatment of hypertension, and it was by Ligand and was acquired by Retrofin, and it has moved into and was proposed as a primary therapy for FSGS. And in fact, it really represented the first drug that was proposed as a primary therapy for FSGS. And it's now trials are being developed to explore the utility of this drug in other forms of glomerular disease, such as IgA nephropathy and FSGS. Next slide. The Duplex trial builds on the DUET study. This was a phase 2 study that included a washout period where people that were on an ACE or an ARB were taken off of that drug, and then they were randomized for a 8-week double-blind period to receive either irbesartan or sparsentan, which ostensibly was thought to represent irbesartan plus, meaning the irbesartan plus the endothelin type A receptor blocker component. And these were the results that were presented at the ASN, I think about two or three years ago, and published last fall in JASN. And they showed that when you combined all of the doses, there was about a more than 2-fold % reduction in proteinuria from baseline. The highest doses were somewhat comparable. The 400 and the 800 milligram doses together also achieved a significantly greater reduction. And the right-hand panel documents the utility of this novel partial endpoint, which John Troost and colleagues at Michigan, we've shown, has a closer correlation, matches closer to complete remission of proteinuria. And you can see that about 3-fold more patients who were treated with sparsentan were able to achieve this modified partial remission endpoint with presumably a improved long-term outcome. But again, DUET was only an 8-week double-blind period. The patients have been rolled over into an open-label extension, which now I believe is extending out to about 104 weeks, nearly 2 years, of open-label therapy. And this has demonstrated that the drug continues to be effective. In fact, there's an increasing percentage of patients who achieve this modified partial remission. The blood pressure is stable. There's no metabolic disturbance that appears later on with treatments such as hyperkalemia, and it appears to be well tolerated. Again, this is an experience based on approximately mid-60s numbers of patients. So this DUET trial provided the rationale for the Duplex trial. Next slide. So this is the overall design. Once again, patients are screened. There are now over nearly 100 sites that I'll show you on the next slide in multiple countries on multiple continents, because the target population is 300 patients. There is this washout period for 2 weeks in which patients who are on an ACE inhibitor or an angiotensin receptor blocker, that medication is stopped. They're then randomized to get ostensibly the half dose, 400 milligrams of sparsentan or 150 milligrams of irbesartan. They're seen about 2 to 4 weeks later, and if they're tolerating that dose, it's advanced to the full dose. This allowance to go to the highest dose was done in consultation with the FDA because of this sort of linear dose response in terms of lowering of proteinuria without any significant safety signal. It was thought best to test the highest dose that was used clinically, which was 800 milligrams. The patients are then treated for out to 2 years, and then there's a 4-week washout period to get an assessment of the acute hemodynamic effect of the sparsentan to ascertain how much of it is related to structural changes in the glomerulus and how much is reversible due to alterations in the intraglomerular pressure and flow. Next slide. So again, the target is ambitious. It's 300 patients with over 200 sites, again, in North America and in Europe and in Asia. Patients have been randomized into the study for approximately a year, and I think this study is approaching the 100th randomized patient. Next slide. The efficacy, this slide summarizes the efficacy endpoints, and again, the study is really quite novel. Historically, as people know, glomerular disease trials have been designed to document hard clinical outcomes, namely a doubling of serum creatinine or the incidence of renal replacement therapy, CKD stage 5. The Duplex trial, the primary endpoint is the slope, the change in GFR from week 6, which is thought to be like a stabilization period after any acute hemodynamic change from the introduction of the drug or irbesartan through to the end of 2 weeks, with the surrogate endpoint being the proportion of patients who achieve the modified partial remission endpoint, namely a protein creatinine ratio less than 1.5 in conjunction with a 40% reduction in proteinuria at week 36. I'll go over in the end what this means, these two endpoints. The key secondary endpoints are the percent change in GFR and the change in GFR from during this washout period. There are a number of safety endpoints, body weight, vital signs, physical examination, edema, because as people know, historically, the main limiting factor to the widespread use of endothelin type A receptor blockers has been the inhibition of the natriuresis induced by an ETB receptor and sodium and fluid retention with anemia and worsening of congestive heart failure. But in point of fact, sparsentan is much more selective to the ETA receptor than most of the drugs that are applied in clinical practice, such as bosentan for primary pulmonary hypertension. And in the DUET trial, while there was some incidence of edema, it wasn't sufficient to cause discontinuation of the drug in any of the patients, and that couldn't be handled with some judicious use of diuretics. And these are the box at the bottom indicates that with 300 patients, there is a greater than 90% power to detect a significant difference in slope between the two time points, and 190 patients are required to achieve a power of 90% to detect a difference in the partial remission response rate. And I'll go over what that means. Next slide. The inclusion criteria are biopsy-proven FSGS or a genetic mutation in a disease-causing podocyte mutation that's been associated with FSGS. And the key exclusion criteria parallel to that on the right-hand side is FSGS secondary to another condition. So again, this would be lupus, where this would be related to IgA. Outport patients would not be included in this trial if they have histologic evidence of FSGS with genetic proof of Alport syndrome. The protocol has been amended to include pediatric patients, which is in fact synchronous and parallels the experience in DUET. The protein creatinine ratio has to be above 1.5 with a GFR greater than 30, and then they have to have a blood pressure within a certain range to avoid any hypotension due to the introduction of the drug. People with elevated potassiums or other medical conditions, type 1 diabetes and all the other standard kind of factors that would be involved are on the right-hand side of the exclusion criteria. And girls, the pediatric patients and all of the patients have to agree to use birth control to avoid any problems with pregnancy and potential birth defects in relation to exposure to the drug. Next slide. So really, in conclusion, what I think it's important that this is a fairly unique study. One is that it really does incorporate this new way of trying to define a clinically relevant endpoint that potentially has greater utility, that would require fewer patients and a shorter duration of follow-up, namely this change in GFR slope. And I'm sure people that are listening into this webinar, they're aware of that series of 3 papers that were put together by the Biostat, the consortium of sites with glomerular disease trials, showing that this is likely to be a endpoint that will be of growing utility. It seems to be correlated with the clinically relevant endpoints, and it does translate into clinical trials that can be performed over a shorter period of time with hopefully a smaller number of patients. The modified partial remission endpoint is also extremely unique to the Duplex trial. In other words, we in nephrology all know how huge of an unmet need FSGS represents and the need to bring new therapies to the patients. And with the in consultation with the FDA, they've agreed that this modified partial remission endpoint can be used about 1/3 of the way through the trial at week 36, which is considerably longer than the Duet trial. But if that assessment at 36 weeks after 190 patients have passed that time point, if they are successful in increasing the number of patients that achieve this endpoint, the FDA will be willing to consider expedited approval of the drug with confirmation and solidification of that approval if after 2 years the hard clinical endpoint, namely the reduction in GFR slope, is achieved. So again, I think sparsentan, it's an investigational therapy. It has the potential to be the first drug to obtain approval for the treatment of FSGS. It's not a targeted therapy, and as outlined by Martin, it's probably a therapy that would be an improvement over renin-angiotensin blockade, but something that would be applicable across the board. It's a crowded landscape. Thankfully, I'm grateful to the number of drugs that are coming to the clinical arena for testing, but I think sparsentan and Duplex are one of the first that have really been launched, and I think it's incumbent upon the community to do our best to complete this trial in a timely and efficient manner. Thanks.
Excellent. Thank you, Dr. Trackman. So in the effort to leave some time for questions, we'll move on to our last speaker, Dr. Demian Model. He's an associate professor of medicine at the University of North Carolina. She's an experienced researcher involved in investigation of genetic and epidemiologic risk factors for CKD, and she's a site investigator for the Poteau trial, a phase 2 study of an antagonist to SLT2. So thank you, Dr. Model, for spending your morning with us.
Thank you so much. Can you hear me okay?
Yes, great. Thank you.
Okay, great. So if you can go to my slide deck. So the Poteau trial, this is a very new molecule. It doesn't even have a name yet. So it's entering phase 2. So it's been proven to be well tolerated in a handful of patients who were administered this drug a single time. And so PF, I'll let you read the numbers, is actually a therapy that's fairly unique in the fact that it works at the level of the podocyte and actually even at the foot process. So SLT is the antagonist that the drug works as, and SLT was actually originally discovered to be a repulsive guidance to axonal and nerve development, and then later was found to actually be very important to development of the kidney. And you can't really talk about SLT, which is actually secreted by the podocyte, without talking about its ligand ROBO. So ROBO is a transmembrane receptor at the basal surface of the podocyte. And so I'm going to talk a lot about robo, although the drug is an antagonist to SLT2. So if you look at panel A on the upper left, we can see that robo2 knockout mice actually have aberrant development of the kidney with ectopic ureteric buds and aberrancies in development of the metanephros. And so actually there have been families with K-cut or congenital anomalies of the kidney and urinary tract who have abnormalities or mutations in robo2. And so why am I talking about K-cut when we're talking about FSGS? Well, robo2 and SLT2 actually are also very important to podocyte formation and nephrin-induced actin polymerization. So if you look at panel C, you can see where robo2 can interact directly with nephrin at the level of the slit diaphragm. And so when SLT2 binds to robo2, it actually inhibits nephrin-stimulated polymerization of the actin cytoskeleton, which is obviously very important to podocyte function and probably to FSGS as well. Next slide. And so, as Dr. Pollack was saying, you know, it's a very complex system, the functioning of the podocyte and the slit diaphragm. And so if you knock out robo2, you can see this in the schematic, you actually get increased polymerization of the actin cytoskeleton because, again, it's inhibiting nephrin's initiation of formation of actin polymerization. So if you just knock out robo2, actually mice are non-viable, but if you institute a podocyte-specific knockout, you actually get aberrancies in the structure of the foot processes. So the two panels on the left, I and K, are wild-type mice, and panels J and I on the right are the podocyte-specific robo2 knockout mice. And as you can see, there's effacement of the podocytes and there's abnormal structure of the foot processes. Next slide. But the interesting thing is that if you combine a podocyte-specific nephrin knockout mouse with a robo2 knockout mouse, and that is not shown here. I actually chose not to show that slide because it didn't reproduce very well, but it actually repairs some of the abnormalities that you see in just a nephrin knockout mouse. So with nephrin knockout mice, they have dilation of the Bowman space, but if you combine it as a double knockout mouse with robo2, you actually get decreased dilatation and improvements in the ultrastructure of the kidney. So what Dr. Liu, who has led these investigations, did was to investigate, well, what happens when you knock out robo2 in a mouse model like hypertension, which is prone to getting secondary FSGS. And they actually combined a hypertensive model along with a MyH9 knockout just for a magnified phenotype. And so here you can see in these three panels what happens. So the wild type mouse in the presence of hypertension has less podocytes than the robo2 knockout, has more sclerotic glomeruli and higher albumin to creatinine ratio. If you then look at the MyH9 knockout in combination with the wild type, they get excessive proteinuria and sclerosis of the glomeruli and decreased podocyte numeration. But if you have a dual knockout of robo2 and MyH9 specific to the podocyte, there is resolution of of all of these abnormalities. So from a mouse model perspective, it is an intriguing target. So next slide, which brings us then to the Poteau trial, which is a phase 2 study. It's going to be over the course of 12 weeks of exposure to the drug. It is open label, and there's going to be 2 sequential cohorts that are involved. So cohort 1 will be screened for the first month, and then there's an 8-week lead-in time, and they'll get IV infusions of the study drug, 1,000 milligrams every 2 weeks for 12 weeks, and then followed observationally for 9 weeks. And once cohort 1 has been fully recruited, cohort 2 will be recruited and will follow the same schematic, but with a lower dose of 300 milligrams. So participants will be involved for approximately 8 months total, and we'll have about 15 visits over the entirety of the study. Next slide. So inclusion criteria. So obviously we want a biopsy diagnosis of primary FSGS, not secondary. It is an adult study. We're wanting patients who still have activity. So a urine protein creatinine ratio of at least 1.5 at screening, and a GFR of above 45, unless the participant has been biopsied within the past year, and they're not demonstrating significant interstitial fibrosis. So we can allow patients in with a GFR as low as 30, as long as the biopsy within the past year shows less than 50%. If the exclusion criteria are collapsing or obviously secondary FSGS and body mass index greater than 40. And next slide. And so because this is a safety as well as efficacy study, there are numerous outcomes. The primary outcome is change in UPC from baseline to week 13. Secondary outcomes are going to be safety and tolerability, so adverse events, adversities in vital signs, lab parameters. We're also looking at anti-drug antibodies and neutralizing antibodies. We'll be studying pharmacokinetics, and then efficacy with respect to partial and complete remission of proteinuria and changes in GFR. So last slide. There are about little over a dozen sites throughout the United States and Canada enrolling for this study. And it's really been an exciting study to be involved in because of the fact that it's such a novel molecule, and it does, again, work at the level of the Poteau site. So enrollment just started less than a year ago, so it'll be several more years. Thank you.
Perfect. Thank you, Dr. Model. So it looks like we do have some time for questions, which is great. I'd like to start with inviting Kelly Helm. I mentioned the manager of patient engagement at FCure, as well as a parent of a patient with FSGS. She is going to pose some questions from the patient perspective for our panel. So Kelly, if you could go ahead.
Sure, thank you. My first question is, how far off are we to being able to match therapies to patients individually?
And I would say perhaps we can pass that on to Dr. Pollack.
Well, I think it's complicated. You know, people argue about whether, for example, you know, so how do we classify people? I mean, do we classify them genetically, histologically, by clinical syndrome? And probably the answer is, you know, you need to do all of those things. We don't know yet who's going to respond to what. And so I think parsing out this information is, you know, will be valuable. So I think you're certainly at a point where we could do for example, genetic testing could tell you that there are some therapies that it's unlikely that a particular person would respond to. But in general, I don't, you know, I don't know how to give a really totally general answer to that question.
And maybe in the same line of this question you mentioned that what we considered as FSGS is now kind of 50, 60 different type of disorders, many genetically mediated. Maybe a question to Dr. Gibson and Dr. Trackman with regard of their clinical practice as pediatrician. When do you do the genetic testing? Do we need to rewrite our book on FSGS, all the epidemiology we have about FSGS? If this is all so many various disorders with all different outcomes, where do we get from there, and what should be our practice with regard of identifying patients for various therapies and actually enrolling them into the trials?
Sure. It's a really good question. It's really a field in evolution, and I think it's clearly relevant to pediatric nephrology because as all of the studies have documented that the yield of genetic testing really is higher in the first year of life. It can be up to 80% of infants with nephrotic syndrome have a genetic abnormality, nephrin, Poteau, or laminin. So they really are invariably tested. I think the question is that we as clinicians have not exactly defined the yield. My colleagues at Neptune, they think that the incidence of genetic mutations may be under 10%. Other people think it's up to 30%. And this may be a task of the geneticist to define what are relevant variants that are disease causing. And then the other thing, the burden of proof on us is to really verify that the genetic information is clinically relevant, because the knee-jerk response is to say that genetic abnormalities rule out a response to therapy, but that doesn't appear to be uniformly the case. So I think it's a tremendous question. I think we need to figure out a way to make sure that this is incorporated into the care without any financial burden on the patient so that we can collect this information, systematize it, and act on it thoughtfully.
Thank you. My second question is, which patients are ideal for both the Duplex, individually, for either the Duplex or the Poteau study?
Amy, do you want to go first? You can go first.
Sure, thanks. So since it is a new molecule, we're looking for patients who have not been tried and tried again on, 4 or 5 different drugs and haven't had any remission whatsoever. Clinical trials are difficult. So we're wanting people who have been exposed to at least steroids, and they can even have been exposed to one other drug. But we're looking specifically for people who show some sign of response to therapy, rather than, treatment-resistant disease, again, where people have had numerous medications and we aren't responding to anything. Or, to answer your first question, we have ways of identifying which patients will respond to what. The other thing that I wanted to add is, it was discussed before that patients with genetic abnormalities are going to probably be less treatment responsive. That is not an exclusion criteria for the Poteau trial, but it would be interesting to see how that would go should we get like a patient with familial FSGS. And then the other entity that I think would be interesting to talk about would be patients with tip lesion FSGS. So that's a specific pathologic variant of FSGS that I think most would say tend to be more steroid responsive and may be a distinct entity. Again, other than secondary FSGS and FSGS, all comers are welcome into the Poteau trial.
With regard to Duplex is not a targeted therapy intervention, so it's projected to have broad utility in the whole population of patients with FSGS, whether it's secondary to a circulating factor and an underlying immunologic defect, or whether it's a genetic abnormality, because ostensibly it's blocking the downstream fibrotic effects that as the disease is progressive. So in that regard, it's a little bit old-fashioned, but then on the other hand, it has a much broader purview. So there really is virtually no restriction and there's no requirement for failure of any specific therapy. There are the standard exclusions to make sure that the interpretation of the efficacy of sparsentan can be thoughtfully interpreted, but there's no mandate for really resistance to anything, and patients can be entered at any time in the course of their disease if they satisfy the inclusion criteria.
So in that same line, Dr. Trackman, Dr. Glassick was asking whether collagen abnormalities, the spectrum of Alport disease, are they included or excluded if they test positive genetically?
They're excluded, and Retrofin is keenly working to design a study specifically targeting patients with Alport because they are, again, an important group of subgroup of patients, but they would not be eligible for Duplex.
Question for the whole group. Are you all in agreement with the use of reduction of proteinuria as an adequate endpoint for drug approval? And are there any potential pitfalls with that, in particular for FSGS, if we use that as a criteria?
Dr. Gibson, can we start with you on that?
I can start with that one. So, we've worked hard over the course of the last couple of decades to be able to find a way to be able to develop therapies for patients that are a feasible mechanism, a feasible pathway. When we use proteinuria as a short and intermediate term endpoint for clinical trials, this actually gives us what we consider to be a clinical marker of disease control, and now is actually an acceptable marker of disease control when it comes to a signal of efficacy within a clinical trial. The reflexive addition of control of kidney function, so preservation of GFR, is also really important. And Sunil, I think you get to the point to say some of the mechanisms of disease that we're trying to reach through our novel pathways and novel drugs may not be a direct proteinuria modifier, but that really becomes the decision because of the disease and the drug mechanism, right? So in general, proteinuria is actually a really nice short and intermediate term outcome. It becomes a nice outcome that tees up your kidney function preservation, but you can imagine some other indicators that would suggest that we might use something else, a different biomarker, for example, which may be incredibly valuable and specifically targeted to a particular therapy.
Dr. Trackman, any thoughts?
I agree with what Deb has said, and I think one of the things I'm learning is that even though it's a fairly old criterion for the evaluation of efficacy of therapy, there's more to be learned, and we're trying to extrapolate more information, graded changes in proteinuria and different thresholds, and recognizing that the implications of proteinuria, the magnitude of changes that need to be achieved may vary from disease to disease. The membranous nephropathy community has made great strides in applying proteinuria for endpoint assessment in that disease, and it may need to be refined specifically based upon the underlying glomerular lesion.
And this is Dia Wagasback in Houston. Along those lines, when you talk about these modified endpoint criteria and things and how we can better adapt them, particularly for FSGS, a lot of the inclusion criteria, especially in kind of phase 2 and small numbers, are, it's a wide range of disease process, which likely multiple underlying pathologic causes. And do you think the modified criteria can help to kind of tease out what's actually drug effect and what is disease progression? That some of these, I enrolled someone with a more advanced GFR and kidney function decline that may not, may kind of cloud the results and data, and some of these drugs may actually be beneficial. We just don't have all the genetic causes and data to pinpoint them at this point.
Many of the trials now are actually embedding genetic evaluation as part of the evaluation at the time of screening, or the specimens are collected and that's part of the statistical analysis plan for the study. And so there's certainly predefined subgroup analyses which can get at those key questions, but also allow you to sort of see the opportunity that a therapy might work even in those populations where you think may be a little bit distinct, but you want to be able to address the question as opposed to excluding them. The more heterogeneous the population, of course, the more generalizable the results, but also the bigger sample size you have to have. So there's always a bit of a trade-off, isn't there, in these activities. And that's part of the hard work of study design, as people really try hard to find, you know, what the problem is they're trying to solve, right, from a patient perspective. And we think about that as patient survival, patients who are feeling and functioning well, and, you know, that early indicator that their kidneys are going to survive because their proteinuria gets to be under control. And all of those make sense, and we think about this across the entire continuum of FSGS. We also think about it within each subgroup, because our activity within each group may be sort of slightly different or slightly easier to be able to detect if you've got a person whose kidney function is down at the 30% mark or a GFR of 30, as opposed to someone who's beginning with a GFR of 90. So you bring up excellent points.
Excellent. Thank you so much. With the interest of time, we are already 7 minutes past. I would like to perhaps give the last question or comment to Kelly Helm as the patient representative, and then come back to thank everyone and conclude. Kelly, any thoughts, any questions or comments?
I just have one more question representing the patients, and that is, what things should patients consider when being asked to be part of a clinical trial?
That's a great question, and I pass it on to our trialists, Dr. Trackman, Dr. Model.
I think I think that we need to make sure that they should be forthright. They should make sure that all the patients should be inquiring of their physicians, and that's what NephCure is doing so well, is to make sure that families and patients are aware of what's going on so that they can be informed as they approach their physician. And hopefully physicians will work together to make sure that they get patients into trials that they're eligible either at their site or work with people in their region, because a lot of these studies aren't done at every single site. We try to work together in a way that makes it more efficient and user-friendly, that patients can learn about the trials and get to the trials in an efficient way that is not too disruptive to their lives.
Yeah, I would second all of those sentiments, but I would also say, in addition to talking with their primary nephrologists and primary care doctors too, is to discuss, you know, the potential therapies that are out there. If, you know, there's randomization, which often in clinical trials there is, whether that's appropriate for them, you know, based on the stage of their disease as well as what they've been on. And then specifically, you know, what for them to inquire about the potential adverse events. You know, oftentimes we list those in the consent forms, and that should be discussed with the participant at the time of consenting. But I think having a proactive participant is really dedicated and knowledgeable and knows what they're signing up for is all the better. Because when we enroll a participant, you know, it's most important that they stay with the trial. And so one of the things that's important to staying with the trial is knowing what they're signing up for. So really getting all the information that they can from the clinical trial team.
Thank you. And Dr. Gibson, any thoughts from your point?
Thank you for asking. The last comments are, you know, we ask the questions of ourselves and our patients, which is really important, which is the trial, how does it compare to usual care? is the trial asking for things that, from a visit schedule, other procedures or extra tests and things to do, is that reasonable? Is it a good fit for me? Can I, as a patient, commit, and those around me commit to helping to make this a successful experience? Those are things that are really important, because when a patient is really looking at a clinical trial, we'd like to be certain that they're thinking about this holistically and to be a good and a positive experience, and one that actually goes from the beginning to the end, because obviously from a clinical trial perspective, everyone begins by saying, I intend to be part of this all the way to the end of the study, and to try really hard not to step out in the middle. We're always respectful that patients are volunteering for this activity, and we always know that our patients are really fabulous in trying to come to an answer for a therapy that's good for them, but also that's good for the population at large. And so we've got a lot of just fabulous volunteers in our community, and we'd like that to be a positive interaction for patients, for their support structure, their family, but also for the physicians and the clinician scientists who are around them.
Perfect. And we leave that the last. And thank you so much. Thanks to our speakers, Dr. Gibson, Dr. Trackman, Dr. Pollack, Dr. Model, who prepared, took their time, and committed and donated that to us to discuss this very important topic to us. Thanks so much to our moderators, Dr. Campbell, Udani, and and Lauren Lee, for being part of this and helping us to spread the word, so to speak, and organizing this. Thanks, and to our partner, NephCure of Kidney International, to bring this collaborative initiative together, and ASN and Kidney Health Initiative for endorsing this and helping us spread the word. So next session will be in October 1st on pediatric clinical trials. So come back again, and in the meantime, we also see you next week on our regular GlomCon conferences. So thank you, everyone, and have a wonderful day or night, wherever you are. Bye.